Welcome to yet another edition of continuing educational webinar series from Vijay Diagnostic Center. I thank you all for joining us today. I am Dr. Gyan Kumar Chaudhary, Senior Consultant and HOD Biochemistry of Vijay Diagnostic Center. So today we are presenting the topic biochemical investigations or markers of female infertility, and this is to be presented by Dr. T. Kinra. So, female infertility defined as the inability to conceive after a year of regular unprotected intercourse, and this can stem from various factors, including ovulation problems or damage to fallopian tubes or uterine issues or hormonal imbalances. So, if the biochemical investigations are of help to that, arrive at a particular diagnosis for the specific treatment, and that's the motto of this presentation. So our presenter today, Dr. T. Kinner, is consultant biochemist at Vijay Diagnostic Center, and she has completed her MD from Gandhi Medical College in 2016, and uh, she will present now. So if you have any questions during the presentation, please type them in the question box in your control panel, and I'll bring them up after the presentation, and we'll also have some time for the questions after the presentations. So now, without any further ado, I turn on the presentation to Dr. T. Kinner. Dr. Kinner, please.
Thank you, sir. Thank you for the kind introduction. Hello, today I'm Dr. Kinara, a consultant biochemist at Vijay Diagnostic Center. And I thank Vijay Diagnostic Center for giving me this opportunity to talk about the biochemical investigations which are used in female infertility. Now, yes. Right. So when we coming to the effectiveness of a test, no, we should be able to eliminate the false negative results, and a test should be so efficient that it should not pick up those which are not positive. And also, it should be cost effective so that it can be repeated again for the patient, and there should be safety for a test. So any diagnostic test should have good sensitivity, specificity, safety for the patient, and effective cost for repeatability. Now, what do we call as an infertility? After 12 months of trying for pregnancy, a couple fails to get pregnancy, then they come to consult a gynecologist. Infertility is labeled if they fail to conceive after 12 months. So, coming to the causes of infertility, not to forget, males play at least 50% of the role in etiology of infertility. For female infertility causes, tubal and pelvic pathology and ovulatory dysfunction give equal weightage, 40% each. WHO has given a classification of anovulation in infertility based on the levels of gonadotropins and estradiol in the blood. So, coming to the first class, the first one is hypogonadotrophic hypogonadal anovulation, wherein the hypothalamus and pituitary are not functioning properly, as a result of which the gonadotropins, namely FSH, LH, will be low. Therefore, since they are not stimulating the ovary, estradiol is also going to be low. So this type of class includes our commonly found diseases like Sheehan's, Kallman's. Stress-induced infertility also comes here, also eating disorder related. Coming to the class 2, which is normogonadotropic normoestrogenic, wherein there is hypothalamic, pituitary, and ovarian dysfunction. The LH and FSH would be in the normal range and estradiol would be normal. But still, there is a problem with the axis. PCOS will come under this category. The third category includes hypergonadotropic hypoestrogenic, where the gonadotropins are increased and estrogens are decreased. This happens when the ovary is not responding to gonadotropins. It's called as ovarian resistance. It's also seen in premature ovarian failure. The fourth class is not included in WHO classification, but I've just included it. It also includes the causes of hyperprolactinemia, which are usually prolactin producing adenomas of the pituitary. So here FSH and LH are inhibited, as a result of which estradiol is not produced. Now, for initial evaluation of infertile couples, NICE has given good guidelines which are to be followed under the following heads. So the first includes semen analysis, and then we do assessment of how the ovulation is and also determine the ovarian reserve in the women. And last, the assessment of fallopian tube patency is done. In this, we will cover mostly about ovulatory function assessment and ovarian reserve determination, because they correspond to biochemical tests. So coming to the assessment of ovulatory function, the first hormone which I'm going to talk about is progesterone. Now, when progesterone in the mid-luteal phase, which means it is almost 1 week before expected menstruation, which falls on the 21st day of a 28-day normal menstrual cycle. If in that phase, the progesterone crosses 3 nanograms per ml, it means that ovulation has occurred in the patient. Now, when do you want to collect this sample? 1 week before the expected menstruation, which means it falls on the 21st day of the cycle. What will you do if a patient has irregular cycles? How do you count? You take progesterone, you measure the serum progesterone levels every week, so that we can follow up when the ovulation has occurred, whether if it has occurred or not. There is also one more test which helps in establishing whether ovulation has occurred or not, which is LH search. Usually the LH, luteinizing hormone, it occurs around 36 hours just before the ovulation has happened. So during this time, it first comes in the serum, and after it appears in the serum, after 12 hours, it is excreted in the urine. So for this, there have been over-the-counter ovulation prediction kits which measure the LH in the urine. But always, this urinary LH is not really that effective, because it has around 5 to 10 false positive and false negative rates. Therefore, it has to be reconfirmed by measuring serum luteinizing hormone simultaneously. And also, not to forget, even in people with PCOS, there is a tonic elevation in basal LH levels. So, highlighting the point again, the mid-cycle peak, and in the luteal phase, we measure the progesterone. Now, other methods used by clinicians to assess ovulatory functions are serial ultrasound, basal body temperature, and endometrial biopsy. Now, what is ovarian reserve? Ovarian reserve is how much and how many number and quality of oocytes are remaining in the ovary, which gives the reproductive potential of a patient. So in a normal menstrual cycle, what happens is, in the early part of the cycle, that is in the follicular phase, the early ovarian follicles start producing minimal amounts of estradiol. This estradiol starts suppressing FSH, and therefore in that phase, initial phase, the FSH is low. If the ovarian follicles are reduced in a patient, there is no suppression of FSH because there is no E2 production, and therefore FSH increases. So what do we conclude from this? Day 3, high E2 levels, they show advanced premature follicular recruitment, and it is correlated with poor ovarian reserve. So, if the FSH concentration crosses 20 international units per liter, we can conclude that any treatment regarding the patient's oocytes is not going to result in pregnancy for the patient. If the FSH level on day 3 of the cycle is less than 10 milli international units per ml, it indicates that the patient has an adequate ovarian reserve. Also, we can test the FSH and estradiol levels after giving a clomiphene citrate 100 mg oral dose from days 5 to 9 of the cycle. This shows how much, whether the patient is going to respond to ovulatory induction or not. So day 3 and day 10 FSH is supposed to be less than 15 milli international units per ml, indicates that ovarian reserve is adequate. If FSH level is increased, it means the patient's ovarian reserve is less. So highly abnormal result, any treatment including the woman's oocytes is not going to work. So day 3 estradiol, if it is less than 80 picograms per ml, it indicates adequate ovarian reserve. If the estradiol is increased on day 3, this usually correlates with advanced premature follicular recruitment. This happens in patients who have poor ovarian reserve. So what happens here is, if E2 levels are high, it goes back and gives negative feedback to the pituitary. FSH production will be reduced, and therefore it masks one of the signs of decreased ovarian reserve in perimenopausal women. Therefore, estradiol and FSH are measured together to exclude this. So in ovarian insufficiency, the FSH will be high, ovary is not responding, and estradiol will be low. So here, patients' oocytes are not going to be enough. You can't do anything to treat them for infertility. These are the candidates who will go for oocyte donation. Whereas in when there is FSH low because of failure of hypothalamus to work properly, in this kind of amenorrhea, exogenous gonadotropin stimulation will be enough for ovulation induction. Coming to prolactin. So when there is hyperprolactinemia in a patient, the earliest signs are galactorrhea, oligomenorrhea, and amenorrhea. However, the differential diagnosis of hyperprolactinemia, we have to think about the drugs like estrogens, phenothiazines, metoclopramide, and methyl-dopa, seizures because of the raised TRH, the prolactin is stimulated, primary hypothyroidism, pituitary diseases, prolactinomas, and idiopathic hypersecretion can be there. There is something called as a high dose hook effect, wherein if the prolactin levels are greater than, are very high, as high as let's say 30,000 nanograms per ml, when we are reporting the test, the values will show up as greater than 200 nanograms per ml. But here at Vijay Diagnostic Center, we have advanced instruments wherein the instrument goes for an auto dilution, and we can really give the exact values of prolactin even if it is increased here. And one more important point to consider here is there are few interferences with this prolactin estimation. In case of patient who is using oral contraceptives or lactation, all these will increase prolactin concentrations. In those patients who have heterophilic antibodies, prolactin levels would be high. Anti-Mullerian hormone. Anti-Mullerian hormone, it reflects the primordial follicle pool. So the advantage with this test is it can be measured anytime during the menstrual cycle, and it is the earliest indicator that ovarian function is declining. So also when a patient is going for IVF, anti-Mullerian hormone levels can be used to see how the ovarian response is when a doctor is planning to take them for IVF. By the way, oral contraceptive pills lower AMH levels, and also AMH is increased in granulosa cells, cell tumors of the ovary. So AMH levels, they they rise up to 20 years, but once they reach fall from 30 years onwards, and during menopause they almost get to undetectable levels. So if a patient has more than zero point 0.5 nanograms per ml, it indicates that patient has good ovarian reserve. Inhibin B was initially tested as a potential marker for ovarian reserve, but it is not regarded as a reliable one right now. Karyotyping is done in infertile female infertile patients who have recurrent pregnancy losses and those who have unexplained infertility with along with other factors like endometriosis or tubal factor infertility, and those in whom the initial treatment approaches and IVF have failed. Antibodies are tested occasionally, but they are under investigations as standard markers of fertility treatment failure. So, what are the other endocrine causes of infertility in women? When there is increased ovarian androgen secretion, which happens as a result of insulin resistance occurring in obesity, it might cause infertility. Primary ovarian failure, hyperprolactinemia, and not to forget the PCOS, wherein there's high serum FSH, high serum LH, and normal or low FSH. Other endocrinological disorders like Cushing syndrome do cause infertility in women. What about hypothyroidism and infertility? Thyroid disorders affect the ovarian function in so many ways, directly and indirectly too, by interfering with sex hormone binding globulin, prolactin, and GnRH secretion also. Finally, they cause ovulatory disturbance and anovulation. And it has been observed that almost 50 to 70% of hypothyroid patients have menstrual irregularities, and many patients associated who have hyperprolactinemia are infertile. So, if in thyroid disease we are investigating for infertility, don't forget to check for free T4 and thyroid antibodies if the TSH is abnormally high. PCOS, as we know, the common biochemical abnormalities seen are dyslipidemia and hormonal irregularities, along with high insulin resistance, which is measured by OGTT, FBS, and HbA1c. There are few indices which measure which you are used as an index for the amount of degree of insulin resistance in the patient. Namely, the common ones which we use are HOMA-IR and Quick-I index. HOMA-IR is given by the formula by measuring fasting insulin and fasting glucose, multiplying them and dividing by 405, we get HOMA-IR model of insulin resistance. If this ratio is more than 2.9, it indicates that the patient has significant insulin resistance. However, if it is less than 1, the patient is insulin sensitive. Quick-I involves a more complicated equation using logarithms by measuring fasting insulin and fasting blood glucose. Well, anyway, here, if the Quick-I index is less than 0.3, it indicates that the patient has very severe insulin resistance. In differential diagnosis of infertility, do consider hyperprolactinemia, non-classical CAH, congenital adrenocortical hypertrophy. How do you confirm this? Morning serum 17-hydroxyprogesterone, if it is more than 200 nanograms per ml, is a screening test, and it is confirmed by high-dose ACTH simulation test. Androgen secreting tumors have elevated testosterone and serum DHEAS. So what are the interferences for biochemical assays which we do in the lab? I wanted to particularly mention this because patients who are routinely exposed to animals, who have pets in their house, they have heterophilic antibodies which are present in the patient's serum, which can sometimes affect the levels of these hormones which are being tested in the blood. Also, the other interferences to hormonal assays in the blood are when there is high jaundice, icterus bilirubin more than 20 mg, hemolyze samples, highly lipemic samples, and also those who are taking biotin supplements. All these interfere with the hormonal assays. So, summarizing the talk for today, abnormal menstruation and infertility in women. It can be the result of a disease of hypothalamus, pituitary, ovary, adrenal, or thyroid. So, if there are regularly ovulating menstrual cycles, the patient should have serum progesterone more than 30 nanomoles per liter on day 21. So, if the serum progesterone is more than 30 nanomoles per liter on day 21, it means that patient is ovulating normally. If the serum progesterone measured in the middle of mid-luteal phase is less than 10, it means that the patient is not ovulating. Thank you. Any questions?
Thank you, Dr. Kinnera, for the informative presentation on this important topic. And now we go ahead and take some questions. Just a reminder to all the audiences that please type your questions in the question box in the control panel. So it looks like we have some questions. One is regarding summarizing the markers, biochemical markers for female infertility.
Oh, okay. Luckily, I have a slide for that. All right. So, while how do you what is the diagnostic approach to infertility in women? The first and foremost starts with history and examination. So we divide the patient into two categories, whether the patient is having normal menstruation or the patient is having amenorrhea or oligomenorrhea, less abnormal menstruation. A patient who's having normal menstruation, we test whether the patient is ovulating or not by measuring the progesterone on day 21 in the mid-luteal phase. If it is more than 30 nanomoles per liter, it means the patient is ovulating. So no problem at all there. Suppose the progesterone on day 21 is less than 10 nanomoles per liter. It means the patient is non-ovulating. So we proceed to test for further hormonal assays. So in amenorrhea or oligomenoric patient, first we rule out pregnancy. When the patient is non-pregnant, we start by measuring LH, FSH, and prolactin. Suppose the patient has high FSH and LH, high gonadotropins, it means that patient is suffering from ovarian failure. If there is high LH and low FSH pattern, this type of pattern is seen in PCOS. If the patient has high prolactin, we should investigate further for hyperprolactinemia to see whether there are any hyperprolactinomas. And if all are normal, further tests are indicated, wherein they do further assess for ovarian reserve, or they assess for the clinicians assess for hysterosalpingography, seeing the ovarian tube patency. Is that
Thank
clear?
you. And one more question: how to differentiate between ovarian and hypothalamic causes for infertility?
Ovarian and hypothalamic causes. Yes. So when there is hypothalamic failure, the gonadotropins will be reduced because hypothalamus is not functioning. Gonadotropins will be reduced and therefore FSH and LH will be low. Suppose there is peripheral ovarian resistance. That means the gonadotropins are not acting on the ovary, or ovary is not able to respond to gonadotropins as seen in ovarian failure. The gonadotropins will be increased, but the estradiol will be reduced. Any more questions?
So now that maybe some more questions will be coming in due course of time. If we get that, we'll address it again in course of time. And so great. Thank you, everyone. We appreciate all of you being here. A recorded version of this presentation will also be available. And thanks again for joining us today. Looking forward to see you again next time. Thank you all.
Thank you.